timing, just grabbing my phone so I can keep the timing absolutely on check, because I've heard how frightening Claudia is. Thanks very much for inviting me to speak. I'm delighted to be here. Thanks in particular to Joe Rafferty, who's kind of recruited me to be part of the Merseycare family. I'm really pleased to be part of that wonderful organisation. This is what you're going to get from me. And specifically, what you're going to get from me over the next 20 or 25 minutes, and the clue is in the title, is the past, present and future of suicide prevention in clinical services. So apologies, quite a lot of this has a UK focus, a UK perspective, but what I hope it does do is tie together some of the things you've heard over the last 2 days. And actually, when I'm breaking this down and thinking about it, this talk kind of corresponds, if you like, to the 3 stages of my career. So I'm a clinician, I'm a researcher, and for the first part of my kind of professional life, really the focus was on getting as much research out as possible, and you'll hear a bit about some of that research. But then about 10 years ago, I did a kind of thought experiment, talking to an audience very much like this, and I said, what if I never did any research ever again, and focused solely on implementation? Would that be a good use of my time? And actually, you know, the audience kind of went, oh, yeah, you know, maybe it would. Now, I haven't given up the research entirely, but certainly, you know, the past few years have been more focused on implementing what we know, and I'll talk a little bit about that. And then I'll speculate on some of the future challenges as well. So apologies, you're going to get lots of graphs, you're going to get lots of data. You know, we never forget in our unit that suicide is a deeply personal, deeply individual tragedy, but one that occurs in a societal context. Okay, so let's start with the past. And there's lots of suicide prevention strategies out there. Absolutely, I agree that clinical services are only one part of the solution. Not all suicide deaths occur when people in contact with services. But, you know, it's recognised in every suicide prevention strategy you care to name, the core role of clinical services. And particularly pleased to see it in the US strategy, actually, in 2024. Effective suicide prevention services as a core component of healthcare. A core component of healthcare. So, you know, I think that's really important. Only 25% of people are in contact with mental health services prior to suicide, but about 50% been to the emergency department. About 80% have seen their primary care doctors. So health services are an important part of the role. And health professionals, I think, we have a responsibility to intervene. If someone's in distress, at risk of suicide, we have a responsibility to intervene if they present to our services. So back to some research, and I can tell immediately I'm going to have some problems with the slides because none of the headers are there, so you're just going to have to bear with me. I'm going to wing it. Okay, so this is one of the original bits of research. Basically, I helped run a project called the National Confidential Inquiry into Suicide, clinical database, every single person who's died by suicide in clinical services dating back more than 2 decades. What that allows us to do is make recommendations to services. And the fact that we've been going so long means that we can monitor the impact of those recommendations. So here are 9 things we thought that services should do. These are mental health services, a pretty eclectic bunch of things, from environmental safety to crisis teams to better follow-up to kind of reviews after adverse incidents. What we did was we did this in all mental health services in England and Wales, so it's the whole country. We looked at services that had implemented not very many of the recommendations, so 0 to 6, and we compared them with services that had done more of that stuff we thought was good. And what we found was that in the blue bar there, that suicide rates were lower in the services that had done more of the things we thought were good, so more of the service changes. So researchers amongst you, it's kind of weak level evidence, you know, it's kind of an association, is it causative? So the other thing we did was a before and after study. So we lined up the date of implementation of all those 9 things, and we looked at suicide rates before and after. And we found that suicide rates fell after those 9 things had been implemented, but they didn't fall in mental health services that hadn't made the changes. And there were three things in particular that led to big falls: provision of crisis care, the provision of services for people with drug and alcohol problems as well as major mental illness, and a system of reviews, multidisciplinary reviews involving families after suicide death. So markers of a kind of, Joe would call it a learning culture, I think, there. And those three things were associated with between 200 and 300 fewer suicide deaths per year. So, an important kind of, an important finding, really. But the other thing I think that kind of occurred to me as we were doing this study is the importance of context. So it's not about the service changes we make on their own. They occur in the context of a service. And this is particularly pertinent, I think, in the context of our current NHS. So this is a simple kind of line graph looking at the association between nursing staff turnover, so how quickly nurses leave an organisation, and the suicide rates in that organisation. What it shows, it's a weak correlation, but it's a correlation that's there. So in organisations which have a high turnover of staff, they're the organisations with the higher suicide rates, okay? And what's even more striking about that is that there's an interaction between the service changes and the context. So in services which had a high staff turnover, those changes I showed you on a previous slide had a lower effect. So in stable, well-run organisations, you make a positive service change there, it's going to have more of an impact. So it's the service changes, but it's also the context. This is quite difficult without the slide titles. I have to kind of actually read my own slides. So here's some other evidence for stuff that works, okay? So the importance of an assessment. So importance of an assessment when someone presents in suicidal crisis. We often use the term self-harm here. The importance of carrying out an assessment. I mean, the slight scandal is that not everyone who presents to our specialist service gets an assessment. I think they should, and we've been talking about this in guidelines for many years. But, it's the how as well as the what. So people are often kind of fixated on the questions they're going to ask, but actually the how. It's about how you ask those questions, having a compassionate, collaborative kind of engagement with the person in front of you. And we know that thing on its own, away from any kind of therapy, away from any interventions, may reduce the risk of repeating self-harm, repeating suicidal behaviour by 40%. Now then, you brought me here to kind of, tell you about some of the research. But the other thing I'm going to do is I'm going to slightly challenge you, and, I hope a friendly way. And this is about kind of screening. So again, apologies that the headings are missed out. It's about screening and screening for risk assessment. And on the face of it, it's an irresistible idea. We screen, we identify the people who've high risk, we intervene with those people's bang. It's kind of irresistible. It's almost irrefutable. But I want to talk a little bit about it. So here's some criteria that our national organisations talk about for a population screening programme. So these are things that need to be in place before you have a population screening programme. So this isn't my guidance. This is guidance that, from National UK Screening Committee. And what I did was I went through the kind of 20 criteria. Now, of the 18 that were applicable, for my money, suicide risk screening failed on 16 of the 18. Now, you might take issue with some of the statements I'm going to make, so please come back at me. So the first thing is there should be an effective intervention for the people identified through screening. You go, of course, we've got effective interventions for suicide. Now, of course, what are you talking about? Well, on the basis of screening, what we identify are people with high scores on various scales, okay? Now, what's the evidence that intervening with that group actually improves outcome? It's actually much weaker than, if you like, the behavioural outcome. So most of the trials are actually on people that have undertaken the behaviour and then you intervene with them. So, I'd say, do we know intervening with people who score high on a screen is going to work? The second one there is there should be evidence from high-quality randomised controlled trials that you put the screening programme in, and it reduces mortality and morbidity. So we've heard about some planned studies there. You might come back at me, you might go, what about that ED safe study, Nav, where they did some screening and then they did a QI approach and it reduced suicide reattempt rates. Now, I would argue in the ED safe study, for those of you who know it, really nice US study, the active ingredient there was the quality improvement. It wasn't screening. But, feel free to come back at me. Other ways where, suicide risk screening might fail, clinical management of the condition, patient outcomes should be optimized. So even before you start a screening program, you've got to have the care as good as it can be. And certainly in the UK, it isn't as good as it can be. All other options for managing the condition should have been considered, because you're going to be looking at cost effectiveness. You need a plan for monitoring and managing. Well, we could implement that. And we need adequate staffing and facilities for testing, diagnosis and treatment. At the moment, in the UK NHS, we don't have that. So here are some doubts for screening from the implementation criteria that someone else has kind of implemented. Here's some more doubts about suicide risk screening from the research we carried out, where we asked every mental health service in the country, give us your risk screening tools. Let's see what you're using. Some services we got back something that was 1 page in length. Other services we got back something that was 20 pages in length. 60 different mental health services in the UK. How many different risk assessment tools for suicide did we get? The answer is, of course, 156 different tools. So the screening criteria, you've got the way these screening tools are currently being used. Of course, there's a whole stuff about accuracy, about discrimination. You heard from Dan and others about that. We kept up being asked what's the best risk screening tool. In the end, we got sick of the question, so we did a study. We compared risk screening tools against clinical judgment for repeat self-harm. And the short answer is some of those risk screening tools that we identified with the literature were no better than that black straight line going down the middle, which is the line of chance. So some risk screening tools were no better than chance. Others were very similar. The top performing, if you like, assessment tool was clinical or patient judgment on how likely they were to repeat. So that global risk marked on a 10-point scale was about as good as the risk assessment tools. And I'd agree with other speakers. It isn't about the kind of discrimination here. It isn't about reducing risk to a score. And even those clinical judgments, the positive predictive values, we could go into what all that means, that the ability to predict is very, very poor, because really, in essence, what you're trying to do is pick an outcome that, in statistical terms, thankfully is rare. So you're trying to pick that needle in a haystack, that individual tragedy amongst the people that are coming through, and that is difficult to do. But what could we do instead? And there's all kinds of interesting things happening to my slides, so apologies. So here's some of the alternatives to this obsession with risk assessment. We can, I think Dan's point about language being important. So don't confuse risk assessment and risk prediction. This idea that we can actually predict outcomes in individual people is a fallacy, and one that I think mental health services have been guilty, we've been guilty of kind of propagating over the years. Instead of a more needs-based focused approach, focused on the therapeutic aspects of the assessment, that link between the clinician and the patient, use clinical guidelines, I'll talk a bit about that later, individualized assessment and assessments with informed management. So it's not just about the risk screening, it's not just about the assessment, it's what you do about it afterwards. And the most challenging thing of all is recognizing that everyone who comes into services is, at some extent anyway, at risk. So a something for everyone approach, what might that look like? Well, this is one of my favourite slides because it summarises 20 years of hard research by the folks back in Manchester in a single slide. These are some of the evidence-based things that help make mental health services safer. You've heard about some of them. Others, I can talk to you about, or we can pick up in the discussion. But these are some of the things that we can implement. We can implement them for everyone. How long have we got, Claudia? 5 minutes, okay. But let's talk a little bit about the present then. I'll have 2 minutes on the present. What's going to help us in the present? The first thing is involvement of people with lived experience, okay? So, the speakers this morning demonstrated that better than anyone else. You involve people with lived experience in service development and management. That is one of the big drivers of service change. The other thing is we need to be smart about how we disseminate stuff. So there's researchers in the audience. I'm going to shock you now. Not everyone reads all of your papers. I promise. Not everyone reads all of your papers. So we do things like we do reports, we do little videos, we do infographics which summarize the research. Services tell us they quite like our reports, but not massively. They kind of like me talking on video, but not really. And what they like best of all is digestible summaries of clinical information. So let's be smart about how we disseminate. Let's be smart about how we implement. So one of the things we've done over time, there's been a big focus here on quality improvement for suicide prevention. So it's locally driven, rapid changes. You measure the changes and you measure the impact. Claire was responsible for funding that. What effect did it have? You've seen this slide before. Didn't actually have an effect on general population rates of suicide. This is mental health population rates, and they fell. Actually, some of the program was in the latter part of the slide, but it's an association, it's not causative, but being smarter about how we implement quality improvement. And it's not just about the numbers. People like me are obsessed about the numbers. It's about the activity. This is about some of the activity that happened along the way. Again, it's summarized in little infographics, whether that's assessments, whether that's awareness raising, whether that's drug and alcohol pathways. All of this stuff's on our website. Okay, in 2 minutes, the future. We've had a new suicide prevention strategy. You heard about some of it. It's got some of the things you'd expect in, but some of the focus is changing as well. So in our country, there wasn't really a focus on domestic violence, suicide prevention, people with neurodiversity, people from LGBT communities, gambling. These are new things that have appeared in the strategy that weren't there before, and I think that's great. But don't you just know it, as soon as you introduce a new strategy, the rates go up, and the rates possibly are going up, although these are provisional data based on England. And part of them going up and part of the future challenge is the headwinds we've got, economic headwinds, service headwinds, ageing populations, conflict, global warming. These are the headwinds that we've got when we're thinking about implementation challenges. But we do, I think, one of the really important things, you had sessions on it yesterday, recognise that suicide is a global problem. So you had, I think that's fantastic. You had those sessions yesterday. I'm really sorry I couldn't attend. 75% of suicide deaths worldwide occur in countries which might be classified as low and middle income. So it's not, if I want to make a biggest difference, actually, I should probably not be in the UK. I should be focusing in low and middle income country settings. Data, we all love it. Alan Woodward talked about data, but it's got to be timely. My colleague in Australia showed the importance of that, dispelling the myth that suicide rates were going to go up in the immediate aftermath of the COVID pandemic. Jane Perkis, my colleague in Australia, said, I'm going to plan this study, we'll get data from everywhere, they'll give it to us, and we'll show that it hasn't gone up. And I said, Jane, it will never be done, but I'm in. You can't do it. It's impossible. But she went and did it. 14 out of the 21 countries, suicide rates fell. In the others, there was no rise. A really important public health message that wouldn't have been possible with official data. This is real-time data, and we need to get better at collecting timely real-time data. We need to get better at tackling groups at high risk. So men in midlife, kids. We've got a big problem with people seeking refuge, seeking asylum in this country. They've got high rates of suicide, people from LGBTQ+ communities, older adults, but also social inequalities. Social inequality is really important, not directly in the gift of mental health services, absolutely, but really important to consider. And then individual settings as well. Clinical settings, primary care is a big one, mental health services, workplaces, as my kids there when they were younger and much more agreeable. So schools are a really important setting, and of course criminal justice. Talk about AI, you've had a bit on that, we can pick it up in the discussion. But I was going to challenge the speakers, important not to overpromise with AI. And for me, the kind of thing that works is the kind of thing Dan was talking about, is how do we use this stuff, not to predict, because I don't think prediction is the thing, but how can they be knowledge support for clinicians? So this is the idea that if you've got a massive database, right, the knowledge support systems say, well, in the last 20 patients who presented like this, these are the things that work for them. On the basis of the guidelines that colleagues produced, this might be the best treatment. And actually, we bring in the latest research, this is what that suggests. So you're bringing in those different things. We're not focusing on prediction with this stuff, the technology. We're focusing on supporting clinicians doing a better, more efficient, perhaps even more compassionate job, because if they've got a bit more time, a bit more stuff at their fingertips, they can do that. I think one of the big challenges is still going to be the economy. Certainly in the UK, service funding is going to be a big problem, whichever government we get. And we know what to do. increase welfare funding at times of economic hardship, and you mitigate some of the mental health impacts. Protect health service funding in times of economic hardship, and you will get a return for your money. And I know the next session's on money, so I'll talk to you about the past, present, and future. Here's a quick summary. So suicide prevention, core component of healthcare. I like that in the US strategy. Good data, we all love data. They're vital, can really help drive prevention. I know some people are a bit turned off by statistics. Stories are sometimes much stronger, but they can really be the foundation of prevention. High quality assessment and aftercare mental health services are essential. System-wide approach is key. Risk screening schools are not. Lived experience involvement, that's the big thing, I think. But then there's some other things, smarter dissemination, smarter implementation that we can do. Lots of challenges coming up, but I think we've got the evidence is still the evidence, and lots of opportunities there that I think can work across the system. And the very last thing I'd like to do is thank all the people back in Manchester who do all the hard work. I just get to talk here and go slightly over time. Sorry, Claudia.